slowly. So definition of valvular heart disease: for the stenosis, that is a failure of the valve, that is obstruction of the forwarding flow. And etiology almost caused by chronic primary crustal abnormalities, the calcification, valve scarring, stenosis. But if you'll ask for the mitral valve, then it is most common complex causes is rheumatic. Where I'm going for the aortic, so the little bit causes are different. Though aortic is rheumatic is common, but usually isolated aortic valve involvement is rare. Usually it mixed with some mitral valve disease. And definition of valvular regurgitation: insufficiency results from failure of a valve to close completely, thereby allowing reverse flow. So it is the entrenching disease of the valve cause this destruction and distortion of supporting structure. Based on the etiology, valvular heart disease, congenital heart disease, and acquired heart disease. So acquired heart valve disease is most frequent. If you ask the congenital, so bicuspid aortic valve, atresia of the valve. So there are many causes of aortic valve disease from the beginning. And these valves gradually lead into the diseases into third, fourth decades. So if you'll identify diseases, sometimes congenital severe aortic stenosis also, aortic atresia also, those patients need very urgent treatment. And acquired heart valve disease is like endocarditis, which causes regurgitation, post-inflammatory, heel scar, rheumatic heart disease, senile calcific aortic stenosis, and myxomatous valve disease. So, most how the clinical consequences come, how the type of valve involved, degree of impairment, how fast it develops, acute form or chronic form, rate of compensatory mechanism, whether stenosis lead to pressure overload in the heart or insufficiency lead to volume overload heart. We have first I'm telling you the basics. To see the valvular heart is the structure. This you will see the upstream and the downstream form. So pressure in upstream chamber is higher than the pressure in the downstream chamber during time of flow when valve is normally open. So hemodynamic abnormality is equal to pressure gradient. So upstream valve, downstream valve, high pressure to low pressure. So this is the basic physiology. Then only we'll have to understand the other thing. Retrograde flow of blood upstream during time when valve is normally closed. It is hemodynamic abnormality, that is volume overloaded. In insufficiency or regurgitations. So how the valve it is present, how it is present. It's general malaise, dyspnea, unexertion, dizziness, chest discomfort, orthopnea, dyspnea, and sometimes these patients presented with heart failure, angina, syncope, or death. So these are the most important uh, that means symptoms. And heart failure is the end stage, and the patients usually very early patient to the death. So how you will diagnose? By the clinical first history, clinical examination, ECG, X-ray, echocardiography, then cardiac cath. So you see the normal valve maintain the forward flow and prevent reversal of flow. Valves open and close in response to pressure and difference gradient between the cardiac chamber. In echocardiography, we see the valve morphology, then gradients. How the what is valve stenosis? This obstruction of the valve flow during that phase of the cardiac cycle when the valve is normally open. Hemodynamic hallmark is pressure gradients, that is flow gradient. Valve regurgitation, insufficiency and incompetence. Inadequate valve closure, that is back leakage. The single valve can both be stenotic and regurgitate already. Just I am repeating this thing. Just to remember how it is the single valve process, different disease process, one valve lesion may cause another, and certain combination of particular variable. What we have read now. This is summarizing this thing. Then in causes, aortic stenosis may be degenerative or calcific, congenital, uni or bicuspid, rheumatic, prosthetic one. That means after valvular heart disease, also patient lead to the aortic stenosis. Aortic insufficiency, acute causes, acute infective endocarditis, sometimes root dissection, root abscess, congenital heart disease like Marfan syndrome, and trauma. Insufficiency lead to aortic leaflet disease, infective endocarditis, rheumatic, bicuspid aortic valve, prolapse of congenital prolapse and congenital VSD, prosthetic, aortic root disease, aortic aneurysm and dissection, Marfan syndrome, connective tissue disorder, syphilis, hypertension, and aortic vector. So pathophysiology. When we will call this, there is critical aortic stenosis when there is severely aortic valve narrowing less than 0.7 centimeter square or less than 0.5 centimeter square per meter square. Hemodynamic hallmark. What is the hemodynamic hallmark? Systolic pressure gradient, aortic valve gradient by the aortic valve flow and AVA. AV flow, cardiac output, and systolic ejection period. 50 to 100 gradients are common in severe aortic sepsis. So it is divided into actually basically, if you would go by the echocardiography, we have to see the jet and or V square. So less than 25, 25 to 40 uh, mean and more than 40 mean gradient. Like mitochondrial flow increases, so does the gradient. Unlike mitral stenosis, resting flows are higher, small AV area, shorter systolic ejection period, larger gradient, significant more than 50 millimeter mercury gradients, then with pressure at rest of asymptomatic. So pathophysiology is cannot heal. Chronic LV pressure overload, concentric LVH, stiff, non-compliant LV increased left ventricular and diastolic pressure, increased LV mass, increased mitral oxygen demand, and these are well tolerated to decades. And once LV failure starts, patient lead to congestive heart failure and leads to the death. Sometimes patient lead to atrial fibrillations. These patients are very poorly tolerated. So because of the loss of atrial creep, rapid heart rate, and acute pulmonary edema and hypertension. These aortic stenosis are these patients usually asymptomatic for many years. Symptoms develop when valve is critically narrowed and LV function deteriorates. Usually bicuspid aortic valve keep to 6 decades, anile aortic stenosis 7 to 8 decades. Classic symptoms triads are the angina pectoris from the start of angina pectoris. Patient usually survive up to 5 years. Heart failure patients survive up to 1 to 2 years. Syncope patient usually survive up to 2 to 3 years. So the natural history studies, patients gradient 25 millimeter mercury, 20% chances of intervention in 15 years. Patient with asymptomatic severe aortic stenosis require close follow-up. Gradient progression 6 to 10 millimeter per hour, millimeter mercury per year. Risk factors, age more than 70, coronary disease, hyperlipidemia, chronic renal. Severity of the aortic stenosis is divided into mild, moderate, and severe. Carotid pulse, if you examine it, normal, moderate, slow rising, and in severe, parvus at target. LV apical impulse normal in mild cases, heaving in moderate cases, heaving and sustain in severe cases. In auscultation, you can, in mild, there is very difficult to find in S4, but in severe aortic stenosis, you will find S4. Systolic ejection clip is common in mild to moderate. And systolic ejection, murmur peaking in early systole in mild cases, mid systole in moderate cases, and mid to late systole in severe cases. S2 is normal in mild, normal in moderate, or single in severe. So aortic insufficiency pathophysiology, left ventricle, LV obstruction. How it really depends. It depends mainly of the size of the regurgitation orifice, diastolic pressure gradients between aorta and the left ventricle, heart rate and duration of the diastole, compensatory mechanism, LV dilatation and eccentric LVH, increase LV diastolic compliance. Then LV volume of valve. LV volume normal in aortic stenosis and dilated in aortic rigors. Wall thickness in concentric LVH in aortic stenosis, normal slightly increase in aortic insufficiency. LV compliance is stiff, non-compliant in aortic stenosis, increased compliance with aortic insufficiency. LV diastolic pressure is increased in aortic stenosis, normal to slight in aortic insufficiency. Ejection fraction, both the cases will be normal. So acute versus chronic presentation of the AR. Acute aortic rigors, suddenly aortic valve incompetence, non-compliant LV and acute. These patients are more dangerous and presented with acute pulmonary edema. So they need emergency aortic valve replacement. And chronic aortic rigors, long asymptomatic phase, progressive LV dilatation, POE, orthopnea, PN. Chronic aortic insufficiency. There is widened pulse pressure, more than 70 millimeter mercury, low diastolic pressure, less than 60. Even zero. Hyperdynamic LV, demonstrate signs, Corrigan signs, Wink signs, Rajib murmur. There are many signs in severe aortic rigors. Auscultation, there is diminished aortic recurrent sound, decrescendo diastolic blowing murmur, post-influent murmur, diastolic flow murmur. Effects due to interference with transmitral filling by impingement from aortic regurgitation.